Welcome to Healthy Frontiers. My name is Dr. Bizzoni. I'm a chiropractor, and this show is dedicated to the education of our viewers. The topic for tonight is women's sports medicine. Did you know that women are 8 to 10 times more likely to suffer an ACL injury to their knees than men? Today we have Dr. Katherine Vadasdi, an orthopedic surgeon and director of the ONS Women's Sports Medicine Center, here to talk about the role gender plays in sports injury and injury prevention. Katherine Vadasdi, MD, is an orthopedic surgeon who is fellowship trained in sports medicine, as well as shoulder and elbow surgery. Dr. Vadasdi graduated Dartmouth College and earned a medical degree at Dartmouth Medical School. She performed a residency in orthopedics at HSS, which is the Hospital for Special Surgery in New York City. And her fellowship training is shoulder, elbow, and sports medicine at the Columbia University Medical Center, Department of Orthopedics. While at Columbia, she was assistant team physician for Columbia University Athletics. Dr. Vadasdi is the recipient of the 2017 Doctors of Distinction Female Trailblazer Award and has been named among the Castle Connolly America's Top Doctors list every year since 2014. Dr. Vadasdi also is an accomplished athlete herself, having completed an Ironman competitions in 2007 and 2009. Dr. Vadasdi also is an alpine climber and has ascended Mount Kilimanjaro, Mount Rainier, the Grand Teton, and others. So I'd like to welcome Vadasdi to the show.
Thank you so much for having me today.
Welcome, Doc. Doc, let's get right into it, okay? So,
absolutely.
What is women's sports medicine, and why is it important for women to know about it?
Sure. So women's sports medicine, I take care of a lot of male and female patients. But women in particular have different needs, and some particular needs based on anatomy, and do suffer from some different injuries. And so when I look at my female athletes, sometimes it's a little bit more complicated to bring in nutrition, preventative maintenance in terms of weightlifting, strength training, to really look at the whole picture. In some of our younger athletes, we're really looking at their approach to nutrition, making sure that they're getting the appropriate intake, and also making sure that they're training to prevent injuries. I obviously see a lot of athletes with injuries, but my ultimate goal is to prevent them from ever happening. Sure. So in our Women's Sports Center, we really take care of active women of all ages, adolescents, young kids, up to more active adults. Right. And we're working with athletes of all intensity. So, student athletes, professionals, and novices who are looking to get more involved and more active at any age. Sure. And we look at the whole picture. We look at any pain that they're having, how we can prevent further injury, and really take their whole life. And so I work together with a lot of my colleagues in the Women's Sports Medicine Department so that we can approach their whole life and everything that may be contributing to some of their injuries or limitations in becoming active or staying active.
Yeah, great, great. So are there specific injuries that women are more prone to developing than men, or is it the parts of the body that are more vulnerable to injury?
There are some anatomic and biomechanical differences between males and females. In particular, we see some of the alignments around the hip and knees are very different, and that can contribute to some hip and knee injuries that I see in a lot of my female patients at all ages, young athletes, up into my more into the adults. Right. And so there are some body-specific things. We also tend to see that women are more flexible in general, so their joints are a little bit looser. So throughout the body, ankles, knees, shoulders, we see ligament injuries. So they can have instability in the shoulder, ankle sprains, ACL injuries that are related to a little bit looser joints that makes them more susceptible to ligament injuries.
Sure, sure. So what is it about the female body that leaves women and girls more susceptible to those types of injuries?
Sure. So I'd say that the number one thing, again, is women, girls in particular, and it really starts in our adolescence when we see the estrogen levels rise in our young females. And what that does is that makes them more flexible. Right. And that makes their joints more flexible, and for a lot of athletes, that makes them a better athlete. They have more flexibility in their shoulder, they may have more motion in their shoulder, and that makes them a better swimmer. Sure. And they may have a little bit more flexibility in squatting down, great for lunging sports, squash and soccer and basketball and all the things that can make them a good athlete, but it also makes them more susceptible to injury. When they land from any sort of lunge, jump, hop, If the knee falls in, it tends to put more stress on the ankle, on the knee, and on the hip. And so I see a lot of injuries related to that. The injuries may be acute injuries like an ACL, where you land in a bad form, and that can be from fatigue or just a sudden acute injury, and you rupture your ACL, or it can just be overuse, where we have an athlete who has slight biomechanical weakness in the hips. The knee drops in every time they squat or lunge, and they get a lot of pain in the front of the knee. And so it can be more of an overuse injury that just comes from not ideal mechanics around the hip and knee that I tend to see, or it can be an acute injury. And I think the key is a lot of those injuries are caused by the same deficiencies, the same muscle imbalances or weaknesses around the hips and around the knees. And we can prevent a lot of that by working on strengthening hip muscles. Quad and hamstring are always really important, but we tend not to be very good at making sure the muscles around the hips are strong, and that would prevent a lot of ankle, knee, and hip injuries in our young athletes and really female athletes of all ages.
Yeah, that kinetic chain, right? It just starts from the bottom up.
It sure does.
Yep, good. So what kind of condition, I'm sorry, let's go back to the ACL, because I really want to talk about that a little bit. So
Absolutely.
A ruptured ACL, an anterior cruciate ligament, is a debilitating injury. Okay,
Absolutely.
we know that. So what can women do to protect their knees, and what are some of the specific exercises?
Sure. So, as you said, the ACL is a really important ligament in the knee. It helps stabilize the femur, which is your thigh bone, on your shin bone, which is the tibia. And that allows you to do any sort of cutting sport, lunging, side to side, tennis, basketball, soccer. There are certain sports that have a higher stress on those, and again, it's going to be the cutting sports are going to be a higher risk where a female could suffer an injury. Most of the time, it's a non-contact injury when we see a young female athlete rupture their ACL. It's acute. It's a big injury. They're normally out of the game. And then unfortunately, they're out for the season and often 9 to 12 months after they've had surgery to reconstruct it. Hopefully there's no other associated injury to the meniscus or cartilage, but it's a long recovery. And the recovery is surgery, getting motion back, walking, running, and then getting back to more of those functional requirements of getting back on a field or on a court. So it's a tough injury, and it's particularly tough, I think, for my young athletes who are in high school, who are balancing academics and athletics, and being part of a team is a big part of that process for them and their growth. And so if we can, and that takes them out of it, having that injury really takes them off of that team environment, and it impacts them significantly in kind of those young, important years. So there are a lot of things we can do to prevent it. And there are some good programs that, again, really help on form, which is focusing when you're squatting or lunging, not allowing your knee to fall in. So we focus a lot on making sure our knee doesn't go over our ankle when we do squats and things like that. But as important is focusing on the muscles on the outside of the hip, so that when you squat down, if you land from a jump when you're playing volleyball or basketball or soccer, your knee is staying directly over your ankle and not dropping in sort of in a knock-kneed position. That knock-kneed position is dangerous, and that's where we tend to see ACL injuries. And so the exercises that you can do are going to be things like clamshells, side-to-side exercises, squats with a band around your knee is a really great thing that you can do at home that focuses on your glutes and your hamstrings and quads, but also really gets the muscles on the outside of the hips. And there are specific programs that can include anywhere from 5 to 10 exercises that can be incorporated into the beginning of an athletic program, whether it's a school team or a club team or a town team or travel. You know, it's important to stretch, but almost as important as stretching is, because females don't tend to be tight in general. They tend, again, as we said, to be looser. So stretching is very important, but the strengthening component to make sure the muscles are balanced to protect the joints, particularly the knees and hips, is crucial. And so those are things we can, I think, do a better job at incorporating into a lot of our young athletic programs. And you teach young females how to do that. They know those exercises, and they've developed good habits in terms of squatting, lunging, landing. Going forward into their adult athletic years, they'll have a better understanding of how to protect themselves.
Well, that's great, Doc. It's most times, as you said, it's an acute injury. Do you ever see where it's subacute or not as an acute problem, but they have an anterior knee pain, and you know you're suspecting maybe this child is in for some trouble?
So I see a lot of anterior knee pain in young females. That's probably the other most common thing, probably the most common thing, and I see in my young female athletes. Luckily, most of the time, it doesn't need surgery, it doesn't need injections, and it gets better with physical therapy. The difficult thing is, it's taken years to develop, and it takes a while to get better. And it's a slow process.
Right.
And it doesn't keep you out of sports, but it's really annoying and frustrating for a lot of young athletes who are trying to get better,
Sure.
and that may be stopping them from getting to that next level. It's just pain in the front of the knee, it's achy, it's sore. Maybe they can get through practice, but then they get in the car on the ride home and it's just throbbing and really burning in the front of the knee.
Yeah.
And it's similar in that the muscles around the hips tend to be weak, the knees drop in, it puts a lot of stress in the front of the knee. And it puts stress underneath the kneecap, in the joint where the kneecap really tracks in the end of the femur. And so again, a lot of those strengthening exercises to strengthen the hip muscle, strengthen the quad and hamstring, and get the appropriate balance can make those symptoms go away. But once an athlete has had them for a year or two, which is often when they wait and come in to see me, it may take 6-9 months to get that better. It's not overnight, and they often want a little bit of a faster fix.
Yes.
And so I think the more that we can do to prevent those symptoms from coming on, those injuries from happening, the better, we're taking care of our young athletes and athletes of all ages.
Great, great. Just a question that comes to me often in my office about orthotics and, correcting if your knees are bowing in. Sometimes it's because your feet may what we call pronate or have like flat foot. What's your thoughts on that, Doc?
I think that's a very important thing to assess, and I look at it in all my young athletes. So in addition to your knees being knock-kneed from weakness around the hips, I look at alignment, and I look at alignment from the hips to the knees to the ankles. And a lot of young athletes are pronated, meaning that their feet drop in a little bit, and that certainly puts you in a more knock-kneed position. That puts you at a higher risk of stress fractures in your shins, tibial stress fractures, which we most commonly see in young female athletes. And that can be alignment, it can be overuse, it can be a nutritional deficit. So we're looking at all of those things, but alignment is a big factor. So I will often have them, as they're recovering from that, work on physical therapy to strengthen the hip, but get them orthotics so that we can bring their arch up a little bit, make them a little bit straighter from the foot down up to the knee and all the way up, because it is a one chain, and we need to make sure that alignment is proper the whole way. If I just focus on the knee, I can guarantee I'm missing a lot of areas within the ankle and hip that we could improve that would make it better. If you just look at an athlete's knee, you're going to miss a big part of the picture.
Great, love that. Okay, so Doc, let's move on down to that. What kind of a conditioning program should women do to help protect against those injuries?
Okay, we touched upon some of them.
Yeah, we did.
But I think in addition to, our athletes of all ages, whether we're students, our young students who are rushing from class, getting to the field, doing one lap around the field, their one quick quad stretch, and then they're getting out and they're playing full time, to us who may be traveling to work, getting off the train, getting out of the car, jumping onto the paddle court, in particular in the winter, you're cold, you get on there and you just jump right into it. Doing a very good warm-up in the beginning of exercise, I think, is key, so that you can prevent some of those acute injuries. And then afterward, doing a good stretching program is important. Again, a lot of females aren't necessarily tight, but stretching still is important. And then I think in addition to whatever sport we do like to play, strength training is important. So we want to make sure we have a component of endurance. So cardiovascular, running, biking, swimming, there are a lot of different ways to get that. But also doing specific strength training is really important in terms of preventing injury. And I think at different ages, you can do that in different ways that are safe, that you can incorporate into your sport specific. So if you're a swimmer versus a tennis player versus a basketball player, that may be a very different set of conditioning exercises. So tailoring it to your specific sport. And then I think as we get older, not that old, but maybe into our 30s and 40s, as we try to keep our entire body balanced, balance is a really key thing, especially as I look at my patients. As we age, our balance gets worse. And so if we can continue to work on that, I think in our 20s, 30s, and 40s, we're better prepared as athletes, and then just living our daily lives. So I think that conditioning program can be very different and not just age-related, but the level of intensity. I have plenty of 80-year-old athletes who put me to shame, and so I wouldn't limit it by age, but I would say it's really based on level of activity and what's appropriate for the sport and for the current condition of the athlete.
Great, great, Doc. I have another question about your thoughts on adolescents, sports specific, one sport type of person, or do you recommend they're open to many or several sports and they find where they fit?
I think it's a really important topic. I think it's a really hot topic that a lot of parents struggle with because there's so much pressure to have your kid be focused on one sport at a very young age. From an orthopedic or doctor standpoint, I see a lot of injuries in our young athletes who focus on one sport all the time. You know, we used to have our athletes play 3 sports, one the fall, winter, and spring, one each season. And then they would go to summer camp and do all sorts of fun, kind of low-key activities in the summer. And I think from an injury standpoint, that kept our bodies pretty balanced. You were doing maybe side-to-side tennis or volleyball or different things in the summer, and then you were doing one sport. So we didn't see the overuse injuries, and I think our bodies got a little bit better balanced. If you put an athlete on the tennis court, for instance, 12 months of the year, they will have overuse injuries. And they will also, their bodies tend to be unbalanced because most sports we do are right or left hand dominant. They're not equal, and so we start to see some overstrengthening on one side. Unfortunately, what we're seeing is not only a focus on one sport, which a lot of athletes are doing, and they're getting hyper-focused at a young age, but then they're doing multiple sports on top of it or multiple teams within that one sport. And so they're not only practicing 6 or 7 days a week, but they're doing multiple practices. And whether or not that's, you know, doubles for swim practice morning and night, or they could be doing one sport in the morning, one after school, and even 2 after school. And so I think that again, it's a tough balance because parents want to see their kids involved. They want to have them on those teams. In order to make the travel team, you need to be on the local team. And that's a tough balance. And so I think it's up to coaches and parents and doctors to play an important role and make sure that we're not pressuring our athletes, our young athletes, and our families and parents and supporting parents to say it's okay not to have your kid do every sport. And it's also okay not to have them focus too young at one. We see a lot of burnout, a lot of young athletes, whether it's tennis or swimming or baseball, multiple different sports, you know, they hit 12 and 14 and they're done. And that's when they should be starting to really love a sport. And my goal for my kids and my athletes is to have them love athletics and love to be active. And active can mean so many different things, and I think if we focus them too early, too young, and too intensely, then they lose that love of it.
I've seen a lot of that
think
myself.
we, you know, want to prevent injuries, and we also want to develop really active athletes for life.
For life, you got it. Great answer, Doc. So is the recovery from an injury different for a woman than what a man might expect?
There are certain injuries that are different. I would take concussion, for instance. We've seen a lot of good data on our young adolescent females versus males. The females take longer to recover from some of the similar injuries. Females may take longer to recover. We may see some symptoms 9 months, a year out in our female students, young adolescent athletes, than we will in males. So there's certainly differences there. I think some of it goes into their strength going into an injury. So an ACL in particular, a lot of our younger male athletes are doing strength training as they're getting at a younger age. We're starting to see more of that in our female athletes, but they may be kind of doing a bit more of a catch-up game in their recovery phase. So I think that they get back to sports around the same time after an ACL, for instance. But I think they probably have to work hard at the strength training or do a little bit more focus on that because they may not have been doing as much of it. In this area, we do see a lot of our athletes working with personal trainers, doing programs, so they're doing some good strengthening. So that does give them a step ahead in their recovery.
Sure, that's great, Doc. Do the injuries girls and women experience change as they age, as they get older?
Absolutely. I think if you kind of generalized injuries, in our young females, I see a lot of, again, anterior knee pain, ACL injuries, ankle sprains, shoulder instability. And that's, again, as their bodies are loose, their muscle strength hasn't quite caught up, and so they tend to get some of those overuse or instability injuries in the knee, ankle, and shoulder. As we get into our 20s and 30s, I see, you know, a lot of adults as they kind of go from school to the workforce, maybe are not able to work out quite the same, and so we see some more weekend warrior type injuries. And then in women in particular, I see a lot of injuries around pregnancy. Because when we get pregnant, we also get more loose again, and so I see ankle sprains, a lot of instability injuries again, and so that's another common sort of not age bracket, but sort of population bracket within females that I treat. A lot of hip injuries, the pelvis gets looser, obviously, for pregnancy, but ankle sprains and things like that as well. So that's a different population that I think we don't always focus on.
Sure.
And then as we get older, I think balance and strength become two major areas where we see a lot of injuries. And so I focus a lot on that. And then I would say sort of in the middle age, 40s, 50s, 60s, a lot of young, really good athletes who were college athletes and, you know, maybe now they have a little bit more time and they're getting into aggressive sports. And that's when I tend to see tennis elbow, golfer's elbow, rotator cuff injuries, meniscal tears, a bit more of the overuse injury. They're, you know, they're strong athletes. They've been active their whole life, and now they're trying to figure out that balance as they need to focus a little bit more on strength and things like that as they keep doing all the sports.
That's great, Doc. And you know what I see often too, with pregnant women, the carpal tunnel syndrome, which is a major problem too, and I know you alluded to those joint problems, and that's one of them, and I know people out there might, what is carpal tunnel syndrome? Maybe why don't you just explain what that is?
Sure. We see, and with pregnancy in general, women tend to get swollen, and so we see a lot of nerves being irritated. So carpal tunnel is a nerve in the wrist. There's another one in the elbow where people think their funny bone is actually a nerve called the ulnar nerve, and when we get a little swollen during pregnancy, those nerves get irritated. And sleeping at night with our wrist bent and our elbow bent, we put stretch on both of those nerves in the elbow and in the wrist, causing irritation. Carpal tunnel is going to give more symptoms in the middle fingers. The ulnar nerve is going to give more symptoms here, but that's a lot of our sleeping position, and then during pregnancy, because of the little bit of extra fluid that a lot of women have, the nerves get irritated. And for many, it goes away afterward, but for a lot, it's really uncomfortable during pregnancy or with a newborn at home. Having numbness or some weakness in the hand can be debilitating.
You got to really go into action.
Exactly. You got to be ready.
Let's just talk for a couple of minutes. There's a couple of conditions that the audience might be interested in.
Okay.
For example, what's a frozen shoulder?
Okay. So a frozen shoulder, also known as adhesive capsulitis, is when the capsule in the shoulder joint gets inflamed. And we don't have any good reason. We don't always know why that happened. It's usually not because of trauma. It just happens somewhat randomly. The capsule gets inflamed, and then it starts to contract. So it basically starts to do this. That first phase when it's inflamed is really painful. And patients come in, I can't move my arm. It's incredibly uncomfortable for them. And then sometimes that extreme pain burns out, and now you're stuck with a frozen shoulder where that capsule is tight, and you really can't move your arm, and I can't move it for them. The patient can't move it on their own, but I also can't move it. And it's really uncomfortable. It's limiting. You can't reach behind your back. You can't go above your head for women to brush your hair, or go behind your back to get dressed. And so the treatment for that usually is not surgical, which is good. It's usually a steroid injection into the joint, which reverses some of that process of the contracture of the cells within the joint. And then that and a combination of physical therapy, stretching it out, for most people will get that motion back. But in the process, it's pretty uncomfortable, and that is more common in females. We tend to see a lot in our 40s and 50s and 60s. There are some other risk factors like diabetes that can be a risk factor that can increase your risk of it.
Yeah, sure.
And then that and there's something called calcific tendonitis, which is another process where you get calcium that develops in the tendons of the rotator cuff. You can get it in other areas, but it's most common in the shoulder. That and frozen shoulder are the two most painful things I see in the shoulder other than trauma. And if someone comes in and they say, I woke up this morning with excruciating pain and they're in tears in the office, I know it's either a frozen shoulder or it's a calcific tendonitis. Those are the two really painful things other than trauma.
And you guys treat that very well at your facility, I'm sure.
I see a lot of that.
Before we wind up, we have 3 or 4 more minutes. Let me just ask you a question. I know coming into your office, you will get a functional assessment, you'll get a biomechanical assessment. Why don't you just explain what ONS, as part of your group, would do for that? What is that?
Sure. So when I see a patient in the office, I have a more limited time and ability to fully assess, again, some of the things we've talked about, their alignment, their strength, the balance between their muscles. And then in addition, some pretty basic things of functionally what they're able to do. And that can be a younger athlete, it can be, again, a more active adult. So when I see someone in the office and I identify some of their injuries, the next step, and for a lot of patients it's doing physical therapy, and it's working with one of our doctors of physical therapy who will take them into the physical therapy department and do a full assessment. And for a lot of them, it's these physical assessment tests. And what they do is they really say, let's not focus on the fact that you have anterior knee pain, but let's look at your whole body and let's find some of those deficits that may be contributing to it, but we want to work on the whole thing. And I will often have patients who come in for tennis elbow and they're doing all their physical therapy on the shoulder because oftentimes it comes from weakness of the shoulder muscles in the back of the shoulder that can then lead to tennis elbow. So a patient comes in and they have tennis elbow and I tell them you need a wrist splint because that's going to protect the muscles in the elbow, and then we're going to do physical therapy to work on the motion in your shoulder and strengthen the muscles in and behind the shoulder. And they look at me like I'm crazy because they say, but doc, my elbow hurts. But oftentimes if I were only to focus on their elbow, I'm not going to get them better. And so a lot of the biomechanical and functional testing is to look at the joints above and below the injured site so that we can really get the full picture and really kind of reverse the process so that we can get rid of the symptoms but also prevent it from coming back.
That's great. Great answer, Doc. Very, very thoughtful. What about platelet-rich plasma therapy as our last thought of a treatment? Go ahead.
Good. So PRP is an injection where you do a blood draw like you're giving blood in a lab, spin it down, and you inject a component, the platelets, back into an area, an injured area. We use it very frequently for areas of what we call tendinosis, where there's really degenerative wear in the tendons where they attach to bone. Elbow, hamstring are two common areas, the Achilles. And those areas have poor blood supply. So the goal with that PRP is to help stimulate blood supply and healing. And it's been shown to be very effective in those sorts of injuries. We also are using it more with arthritis in the knee. So rather than a steroid, which may just calm down the inflammation, PRP may actually help with a little bit of a healing process, not going to reverse the wear of the cartilage, but can stimulate some healing so that patients are more comfortable with arthritis. So we're using it a lot more. It's safe, it's your own tissue. We're not worrying about some of the side effects of a steroid going around a tendon. And it can help stimulate that healing process. And often it's used in combination with braces, with physical therapy, with rest. And rest is a big part of how effective PRP is going to be, is doing the injection and giving that area, that injured area, time to heal.
That's great. Certainly cutting edge here at ONS.
Absolutely.
Thanks for being on the show, Doc.
Thank you so much for having me.
Welcome. You can learn more about ONS Women's Sports Medicine Center and Dr. Vadasdi by going on to the ONS website, which is onsmed.com. ONS has offices in Greenwich and Stamford, and there will soon be an office right here in Westchester and Harrison, New York, as of the end of August. I believe it's August 28th. So thank you for being on the show.